Hello and welcome to Healthline 3. I'm Terry Simmons. Today we're talking about brain tumors with Dr. Jake Wang, radiation oncologist with Willis Knighton Cancer Center. We'll be taking your calls throughout the show, and as a reminder, please make sure you're in a quiet room with your TV turned all the way down before making your call. The number is 318-219-4569, and you'll see it throughout the show at the bottom of your screen. And be sure to call us to get answers to your questions about brain tumors by speaking directly with Dr. Wang. Thank you so much for being here.
Thank you very much.
So let's go ahead and talk about again what we talked about earlier during the midday news. Let's explain what radiation oncology is.
Radiation oncology using basically is a specialized radiation field in radiation that we use radiation to treat tumors. It can be benign tumor or malignant tumors or cancers. And there's also other things that we can do for radiation treating non-cancer related issues in the brain. And we can talk a little bit about that later as well.
Oh yeah, definitely. And tell us a little bit, I'm fascinated by how you chose this field and particularly to work on brain tumors. What was it about that?
So I was interested in cancer when I was in medical school, so I tried to explore different options. I went to look at different, as a surgeon, as a medical oncologist, and then I stumbled upon, actually I didn't know about radiation oncology, but I stumbled upon this field. And then realizing that radiation oncology actually is very specialized, doing a training in oncology and basically focusing on cancer care for the 4-5 years during their training before becoming a radiation oncologist. And then they also combined a lot of the technologies, advances, and that kind of fit to my background of engineering, so that was a good fit.
That sounds fascinating to me too. When you said engineering, I can see that, how this affects with that engineering kind of mind. So tell us about brain tumors in particular. Are there different types of brain tumors?
Yeah, so of course. So brain tumor, actually you can think of it as a couple of different categories. I think the most common ones is actually you can think of it as we call the metastasis. Basically it's a cancer from other places that go into the brain. For example, lung cancers, breast cancers, some cancers that are from other places that go to the brain, we call the secondary metastasis. That's actually the most common brain tumors. The other type is we call the primary brain tumor, which are the tumor directly derived from the brain tissues, such as we call the general term is called the gliomas. And those are usually malignant and infiltrative. And we can separate into higher grade or lower grades. The third categories I would say will be kind of what we call the benign tumors. Those are tumor keep growing but it's not invasive or infiltrating. For example, such as meningiomas or pituitary adenomas. Those are benign tumors that grow slowly but not infiltrating to other places.
And I want to get to that in a minute too, because it's interesting to me that we can have a benign brain tumor that you may or may not go in and take care of and get rid of. So tell us about first, when something travels to the brain, are there certain paths and certain cancers in the body that will go to the brain, or is it just any cancer in the body might end up going to the brain also?
Yeah, that's a good question, because sometimes we don't know exactly how the cancer get to the brain. But there are certain cancers that we see more commonly spread to the brain. Lung cancer, for example, pretty common. It's a common cancer, and then we see a lot of lung cancer that goes to the brains. Breast cancer, just for the vast majority of the number of breast cancer patients we have, sometimes we see some breast cancer patient have spread to the brains. There's other kind of cancer that go to the brain, like skin cancer, such as the melanoma, and other cancers as well. Generally, we think of it as kind of like two pathways. One pathway is the cancer cell get to the bloodstreams and goes to the brain and crossing the blood-brain barriers. The other is cancer spread through the lymphatics, going to the lymph nodes and spread to places. But regardless, once it's spread outside the original site, it's a stage 4 or metastatic disease. And we always need to think about controlling systemic disease while but also that's the most important thing, but then also consider some of the local therapy, because when cancer goes to the brain, they can cause a lot of symptoms and cause some local effect and cause symptoms that can be detrimental.
Definitely. So when we talk about primary cancer that is developed from the brain tissue, that's where it starts, that's where it is. Are there certain causes? Do we know what causes certain brain tumors to develop there?
We get that question a lot, and it's interesting. I don't think we have a clear, really a cause for the brain tumors. And the other interesting thing, like comparing to other cancer going to the brain, primary brain tumor oftentimes it doesn't spread outside the brain that often comparing to, it doesn't go the other way around.
That's
and why that
interesting.
happens, we don't know, but it's just the natural course. But we do know that when a family member has certain brain tumors, then other family members may have increased risk of brain tumors, although it's not a one-to-one correlation, but we think of it as a risk factor that taking into consideration, especially if multiple family members have the similar type of tumors, then definitely we should talk into the genetic counseling and do some screening and sometimes analyzing the tumors and kind of see if certain mutations that can kind of like increasing the awareness of screening down the road.
So not necessarily hereditary, but risk factors to pay attention to.
Yeah.
Do you see that in your practice? Do you see many family members also having brain tumors?
Not direct correlation, but it's not uncommon that we see a family member and an additional member have if you add additional history, you find uncle or family or grandparents has certain kind of the tumor to start with. Yeah.
So do you see it more generational rather than brother sister?
It can be it could be both.
Either, it's got to be very interesting to you too to do that research.
Right, and there's also certain mutations that we know, and that can cause additional tumors. But usually, if it's a hereditary certain type of mutation type of tumors, the tumor usually develop earlier in the years. Right, so if I see pediatric patients as well. Unfortunately, brain tumor is one of the common pediatric cancers, and that's quite devastating for a lot of families. Usually for kids comparing to adults, brain tumors are usually more genetics or gene related, and then we can find out certain mutations from there. And if you have a young family member have mutations, then we definitely need to screen additional family members.
That's got to be devastating when you see that too.
Yeah.
And so let's talk about benign brain tumors. So it's interesting. So you may have one that's definitely not infiltrating the brain, or it's just there maybe on the brain. And there's times where I hear that they've got a brain tumor, but we're just going to leave it where it is. They're slow growing, or it might be too dangerous to go and operate. How do you, like with other tumors in the body, it could be with a needle biopsy or go in, how do you decide if something's benign or malignant in the brain?
That's a good question. Yeah. So there are certain characteristics we can find on the imaging that's suggesting whether these are more benign or malignant. These days, there's also advanced imaging techniques. For example, some of the additional, we call it advanced brain tumor imaging, such as spectroscopy or the perfusion scans, that can further characterizing the tumors, and that can give us a kind of like clue whether these are more aggressive versus more benign. And there are certain tumors that they have such a characteristic on the MRI, we can almost think like 90% that's that diagnosis. Although I always tell the patient it's not 100% that certain. In order to confirm that, I always still need a tissue diagnosis, which is involving a biopsy. So when sometimes for benign tumors, oftentimes it's found incidentally. Say meningioma, if you scan 1,000 patients, you probably will pick up a couple patients that with a meningioma, benign brain tumors, that's not causing symptoms, just pick up incidentally. In those cases, we sometimes say, okay, it looks like meningioma as on the imaging. We should repeat a scan in 3 to 6 months just to make sure that it doesn't grow fast, right? And then if we establish how fast it's growing or how fast it's not growing, then we kind of like know it's benign or malignant from there. Because getting a tissue or going a procedure, invasive procedure, has its own risk, right? So we really need to balance the risks and benefits, whether this is worth taking the risk and benefit of doing it or not. But I think these should be a discussion that you should have with your doctors, and oftentimes this involves the neurosurgeons that can give you a good kind of risk assessments. There's also depends on the location of the tumor. Some locations are a little bit tricky, that involving a lot of critical structures. When you're going in needle or you open up, it has a lot of risk of damaging surrounding tissues. And if it looks like a small lesions not causing issues, slow growing, sometimes we can watch it. But the caveat is that I think it's important to establish how fast, what the kinetics we call, and before we make the final recommendations.
It's incredible. I've heard stories, and so I'm glad you're here so I can ask you this. I always have a Terry question. So I have heard benign tumors that sometimes you'll find something that someone has maybe, they're so slow growing that they've had it almost their whole life and they don't even know. Is that true?
Yeah, it is true. Yeah, so some of the benign tumor, for example, like meningioma we mentioned about, the pituitary adenomas, the acoustic neuromas, those are all benign tumors that on average typically grows about maybe 1 millimeter per year, or even smaller, right? So we sometimes we have a patient that had gotten in a car accident, did brain scans, and saw there's a tumor. It was maybe like a 10 centimeter tumor there, but it had never caused any symptoms. The patient never know about it, so we know it probably been there for a while, hasn't been causing any problems. But sometimes, when they get a big size, when they get to a big size, it sometimes can cause some mass effect. But interesting in the brain is that when they grow slowly, sometimes our brain can adapt those changes. But when they grow fast, our brain usually couldn't accommodate, so we see more symptoms where the patient have a more rapid growing tumors.
Our brains are so amazing, aren't they?
Yes,
God,
yes,
it's incredible. So what do you mean adapt? Will it actually make room for the tumor? Or?
No, so our brain is designed to prevent things from coming in and out, right? So we have the brain tissue, we have a meninges, which is a rubbery layer wrapping around it, and we have bones, like the scalp bones that kind of encase around this. So all these trying to prevent things from coming in or prevent things from going out. That also means there's not a lot of space. So then when you have a tumor that's growing, and sometimes, depends on the location, sometimes can cause obstruction or blockage. And that can increase the pressure in the brain, and that can cause symptoms. So I think not just the size, but also the location and what's surrounding it can all affect how the patient presented in this. And if it's small, our brain can have some room to get used to, and it's still growing, our brain can have room to get used to it. Yeah.
That's incredible.
Yeah.
So,
but if it's a faster growing tumor, then our brain doesn't have the time to get used to it. Then the symptom, you can see the symptom much more rapidly.
Right.
Yeah.
And is it just the pressure somewhere, or is there some kind of cells in our brain that are recognizing it as unfamiliar and?
No. So the brain. Our brain doesn't like the pressure. So when the change in pressure in the brain, then the brain may not function very well. So sometimes some of the common symptoms people may have, sometimes the headaches, sometimes nausea. And in some cases, if you're looking back for some of the patients, you ask a family member for the past 6 months, they may notice that the family member, the memory is getting worse. They're kind of like more quiet, not talking, not as active as before. Sometimes very unspecific things, but if you're looking back, you kind of see some personality changes, some minor things that's a slower process that you couldn't pick up right away, but over the couple months, you kind of see the difference. But again, these are kind of non-specific, or we call it retrospective, looking back. So it's hard to really pinpoint exactly when it happens, because a lot of time the patient asks how long the tumor has been there, without having, like, in a way, I always tell the patient that because this is a one snapshot of the timeline, we don't have the image before. If we have an image before 6 months ago, and now we can have an image compare, we kind of see how fast the tumor is growing. But if we never had any imaging before and just have a snapshot in the timeline, it's hard to determine how long the tumor has been there.
I would think that's probably pretty common, because not often are you going to have any images of your brain ordinarily. It's not something you check on a regular basis, so there's no baseline.
Yeah, and like some other cancers that we have screening guidelines, like breast cancer, colon cancers, like brain tumors, usually we don't have a clear guideline what to do with the screening. We don't screen for brain tumors in this case. Yeah.
And if something, how fast can a tumor grow? Because I mean, it seems the symptoms probably are gradual, or you don't all of a sudden start having all these symptoms that lead to a brain tumor.
Right. Yeah. So I think if it's a malignant type, either the metastasis or primary brain tumors, malignant brain tumors, they're usually faster growing, so we can see the symptoms in sometime month. But then if it's a slower growing tumor, like a benign tumor we mentioned about, those could be years that we never know about. Yeah. Yeah. There's also some other benign tumors that that can secrete hormones or have functions, and those can sometimes cause additional symptoms, like specifically in this case pituitary adenomas. Although they're benign tumors, because of their origin arise from the pituitary gland, which is the gland that making some hormones controlling the body, that can have some effect on the body, and that can be picked up by the endocrinologist or even very good primary care doctors. Yeah.
So are there any kind of blood tests or anything, if you're getting something, other tests that might lead to that? Or
right now, no specific test, but that's a very interesting evolution actually. These days, there's additional molecular testing for the tumor, tumor cell screenings, and at least right now, I don't think we have a blood test for tumor, but I'm hoping that as the medicine advances in the next 5-10 years, we'll have something to give us a clue to the direction to move on to.
So right now it's just imaging.
Mm-hmm. Yes, imaging is the most important thing.
Yes.
Yeah.
And so besides yourself, and you talked about neurosurgeons, are there other health professionals that are involved in when that can come in and help someone who has a brain tumor?
Yeah, I think that's brain tumors involving a lot of different fields. So oftentimes we in our practice we have called a tumor boards. Yeah, so in oncology we have a tumor board. That means that we have the surgeons, the radiation oncologist, the chemotherapy doctor, which is a medical oncologist, pathologist, radiologist, and those, and then other people that are involved in the care to helping the patients, and sometimes depends on the after the surgery, depends on how they're affecting the patients. We may need some physical therapies. We may need some occupational therapies for the rehab, and those are all involved to helping the tumor patients, brain tumor patients.
Yeah, speech therapy,
yes,
I'm
speech
sure,
therapies,
depending on what area of the brain.
Exactly.
Is there any one area that tumors show up more than others?
Not specifically. I think depends on the. So there are. So brain is actually very interesting because brain basically controlling who we are in a way, right?
Yeah.
And there's different part of brain controlling different part of the functions. Some control the motor, how we move our muscles. Some controls how we feel the surroundings. Some are like how we process the information, and some are our emotions, right? So all these are different part of brain can have different part of functions, and oftentimes it's not just one part being affected, and depends on where it's affected and how it's affected, and the patient can be presented with different symptoms.
Yeah.
Gosh. Yeah, but no specific area has prone to certain tumors or not. Yeah.
Is there, which area of the brain is it more risky? Is there one area that's more risky to operate on? Is there any one part that affects more? I know they all affect different parts of our...
Yeah, so I think we can think of it as different approaches, right? So some areas are more higher risk for surgeon to get into. For example, some of the areas are in a dedicated area, have a lot of structures around it, including nerves, optic nerves, for example, brain stems, and those areas that, or some area has a tighter space, right? All those areas or deeper in the brain that have to go through tissues to get to the location. Those are a little bit more tricky to get to and has a higher risk for the surgeons to get into. But comparing to other areas that kind of like on the surface of the brain, that's when you open the skull up, you see the tumor right away. That area is easily accessible, right? And there's also area affecting the functions, right? For example, if the tumor is involving in the controlling our arm, for example, if you need to remove that tumor, you sometimes may damage the surrounding tissues in that controlling their functions. So those are the things involving the surgical risk. But in a way, I think radiation in a way can complement that, because radiation is non-invasive. So for us, it's easier to less of a risk, or it's still a risk, but then the risk may be lower when treating with radiation, when the tumor is deeper and harder to get from the surgeries. So that's the important part in the tumor boards. We discuss with the surgeons and the other specialties what approach should we use to treat these tumors, and oftentimes it's not one versus another, and how do we combine getting the best, using both modality and generating the best approach. For example, sometimes it's a big tumor in an area close to the critical organs, the surgeon knows that if you go in, can have a lot of damage in the surrounding area if he has to remove all the tumors. However, he may go in to debulk a little bit, remove as much as they can. We call the maximum safe resection. But then, knowing that they may have a little bit of residual tumor left behind, then we follow with the radiation. Right? It's kind of like cleaning this area up and making sure the residual tumor doesn't keep growing. Right? So that's and kind of a combined approach that may generate the best outcome instead of trying to do heroically doing surgery to remove everything you can but cause a lot of damages.
And does it ever work in the other way around? Because you hear a lot of times someone will have surgery and then radiation.
Yeah.
Does a neurosurgeon ever ask you to go in? Does radiation shrink or maybe make it better and then surgery? Is it reversed sometimes?
Yes. Sometimes we do the opposite. Taking like brain metastasis, for example, like the cancer coming from other places going to the brain. Traditionally, if you don't have one lesion like going into the brain, while other diseases are controlling the body, we often want to do surgeons go in to remove that lesion followed by radiation afterwards. Because study shows that if you only do surgery, the chance of cancer coming back is high. But when we add the radiation on top of the surgery, we can reduce the chance of it coming back. However, these days, there's newer studies showing that there's potential another approach to do radiation before the surgery, and knowing that surgery may be hard, we may be able to use radiation to shrink the tumor a little bit, clear the margin for the surgeon or easier, so then they can remove the tumor more entirely and more completely. And that's which approach is better is actually active area of under investigation. There's studies trying to study each one of them. Yeah.
And so how does it work? How do you apply radiation in the brain? What's the whole process? If I come in and I have this done, what am I going to experience?
Yeah, so maybe we can back up a little bit about looking at what kind of radiation we have. Yeah, so I think there's basically a couple of different tools of things type of radiation we can think of. I think the most common we call the standard type of radiation. We can think of it as X-rays. You hear about X-ray radiation. That's the same X-rays you get from the CT scans or chest X-rays. Those are X-rays you don't feel anything during the treatment itself. We use high energy X-rays to aim the tumors, and the X-rays basically how we use this, we try to deliver these high dose radiation to the target where the tumor is while protecting surrounding areas, right? And that's we call the X-ray radiation. Another type of radiation is something we call the proton radiation. That's a different type of radiation that use proton particles. And the special thing about proton radiation is that they can deliver the radiation to the target while have no dose outside the target areas. So it's a more precise radiation, especially important when the target is close to the critical structures. Also important for the developing brain, for example, pediatric, like kids that when we need to do radiation, those are very helpful reducing those to those areas. The other tools that we have is something called radiosurgery. It's not knife or surgeries, but basically using X-ray radiation to deliver high-dose radiation to a very small area in a compact course. Generally, for the X-ray radiation, proton radiation, we talk about we need to spread the radiation dose out for a course of a couple of weeks, of course. But for radiosurgery, we pack all the dose in 1 to 5 shots, basically limiting the dose to these areas. And then finally, there's a kind of a technique we call brachytherapy. Basically, we have a radioactive seed that we implant into the brain with a surgeon in the operation room and emit energy from radiation from the inside. And that have to be done in the operation room, but the good thing is that it's done together with the surgeons. And those are kind of the general category of the tools that we have in the radiation fields that utilizing to treat the brain tumors. And as in Willis Knighton, we have all these tools that can help to select what is the best modality to treat certain kind of scenario or situations, and then combine it to other specialties to provide care to the patients. So then back to your question about what is the process like. Most of the patient we treat is radiation coming from outside. So when the patient come in, we of course we need to get all the information, including imaging, including diagnosis, and then we do a radiation planning sessions. The patient come in with the plans that we call the simulation sessions. The patient usually need to we have a couple of scans, and then we try to make sure the patient think about how we need to treat the patient every day with the radiation. that means that we need to think about where the target is and how the setup can be reproducible. In the brain tumor settings, we usually make a customized mask, and that the mask is help the patient to stay still on the table every day.
Oh.
And the patient lay on the table, we put a mask on, and then we do the radiation from there. So we do the planning session first, and followed by having a plan, and then use this mask every day to help the patient lay on the table and deliver the radiation.
That's incredible. So when you're delivering it with a shot, are you injecting the actual tumor? How does it?
Oh no. I should revise that. When I say so radiation coming from outside, so we radiation is not invasive. So we use X-ray or the proton beam or the radiation beam to aim where the tumor is. In a way, radiation we need to know where the target is so we can aim it well. Radiation is we call the linear. Generally, for the typical radiation, X-ray radiation, we use a linear accelerator, which it's a big machine. You lay on the table, machine moves on, you give you radiation. We design the beam to aim the target, so you don't feel anything during the treatment. You lay on the table, the machine moves to where we want to deliver, and deliver the beam to the site. Yeah.
So the radiation beam can go through the skull to
yes.
exactly where it's supposed to go, and it doesn't hurt at all.
It doesn't hurt. Yeah,
That's amazing.
Yeah, oftentimes the patient will ask, "Well, does it hurt?" And then after first treatment, they often that's it, and because they don't feel anything during treatment themselves. Yeah,
that's incredible.
Yeah.
So are there any side effects to that?
Yeah. So first of all, I want to clarify that most of this radiation course is most people go through the radiation without problems. Like 80-90% of patients go through radiation without problems. Some people feel a bit tired. Some people feel some minor issues like headaches, some nausea, but usually those can be easily taken care of by the medications. So our job during the radiation course is actually, once the patient starts, we kind of check with the patient and making sure if there's minor symptoms, we can issues we can help to treat. And usually some medication can get you through the treatments if some of the symptoms that patient develop. Very rarely there's some issues that develop that's not ordinary. Then we kind of see we need to think about what happened, and sometimes it's complication from other things, including combination with the chemotherapy or after surgeries. So let's say that basically that means that we need to cooperate and work with other specialties and work together, taking care of our patients and monitoring things closely. Yeah.
So what are some of the considerations that we have or a patient needs to consider, or that you consider with a patient first coming to you with a brain tumor?
Yeah, so I think we need to start with so first of all, let's start with the patients, what symptoms the patient have, and what do we need to take care of the symptoms first, because if the patient had headaches, have nausea from the tumors, then we want to take care of less symptoms so the patient can feel better, right? And then once the patient feel better, we can think about how to treat the disease, or we need to diagnose what it is and determine how to treat the disease. So oftentimes when the patient comes with the symptoms, we worry about the tumor, we do the scans, and then we have a tissue diagnosis, and then we work with the team that I mentioned about to discuss how is the best approach to treat the tumors. As I said, oftentimes depends on diagnosis. We need to determine what approach to do. Sometimes one modality go first versus the other in order combinations.
Do you ever have someone with a benign tumor who wants it out?
Yes.
Just because it makes them very nervous, and is it up to the patient?
So oftentimes we present the patient options, right? And the patient have and benign tumor, usually the first route is surgery, and then they do surgery, but then but sometimes the patient is not a surgical candidate. For example, had a stroke, heart attack, risk of complication is high going through the operation room, then we can talk about during the radiation. And again, this is oftentimes we can have a discussion with the surgeons and the patients and all the teams to discuss which is the best approach. And patient preference is definitely is something to consider to making the decision in this process as well.
A lot of options,
yes.
A lot of treatments. Yeah. Fascinating. Yeah. Really interesting. So would you like to give the phone number? Do you have the number to your office, or let people know how to reach you if they'd like to?
Yeah, so if anyone has any questions about brain tumor, feel free to call our clinic. Our number is 318-212-4639.
Okay, and it's Willis Knighton Cancer Center.
Yes.
And well, thank you so much. This has been so informative, so interesting to talk about brain tumors and symptoms, and we really appreciate your time here. It's been a pleasure meeting you.
Thank you very much.
Okay. And everyone, thank you so much for joining us at Healthline 3. We enjoy you being here. We love informing you, and thank you so much for watching. We'll see you next time on Healthline 3.